We can hear you.
Excellent. I can hear you all as well. Thank you for having me. Are we ready to begin?
Yes.
Lovely. Well, let's get started. My name is Dr. Melani Kane, and I jokingly say, a real pharmacist. I just had the pleasure of working as a cannabis pharmacist in Minnesota's pharmacist-led dosing state. So a little bit of background about myself. While working in the dispensary, I did co-found the International Society of Cannabis Pharmacists. Our goal is education as well as empowering healthcare professionals to be involved with medical cannabis. It's not one of those things where you can just ignore it at this point, especially with the amount of states and territories that allow for adult use. So you can't just close your eyes and it'll go away. So really encouraging healthcare providers to be informed and educated on potential side effects, interactions, and clinical place in therapy. So mandatory disclaimer, medical cannabis is not FDA approved for any condition, and everything I'm presenting is under investigational use only. Here's an overview of our presentation today. I'm going to start with some pharmacokinetics, and I'm really going to focus on the formulations that have PK/PD information, so basically anything that's peer-reviewed. Unfortunately, for Florida, I do not have anything significant, anything at all, on intranasal. So I skipped it, made an executive decision. And then we're going to talk about adverse drug reactions. What kind of pharmacist would I be if we didn't discuss drug interactions? And then last but not least, we'll discuss the process for doses and adjustments and how we determine which way to go. So starting up, I like to start with some background definitions. This is just what I would do in my patient consultations because the patient education is the most important for clinical success. And I'll preface this just knowing that we had the older adult previously, so patient and or caregiver. But patients need to understand the difference between onset, duration, as well as the fact that just because it starts to work onset doesn't mean that's the time to the maximum effect, which is what we call Tmax. So that will help determine not only if the drug is working, but when it's appropriate to redose, and that ties into the duration as well. So for inhalation, for example, this will be our fastest acting formulation. It goes through the lungs, so it doesn't take very long for the medicine to travel from the breath to the blood to the brain, which is our principal site of action for a lot of these targeted symptoms for THC specifically, pain, sleep, nausea. The challenge is just because you start to feel it doesn't mean that is the maximum effect you will feel. So even if you start to feel it within the first minute, I'll tell patients to wait a solid 15 to 20 minutes before redosing, or they weren't sure they took a puff, still wait and see, because sometimes you don't always have that vapor if you're using a cartridge or vaporization. So much easier to prevent side effects than to treat them, especially when it comes to cannabis and just the variability within each body. So I would say safely, 90 to 95% of my patients will fall within that onset of 5 to 20 minutes. And that would be when they could expect their next dose if they needed it. So if they wanted to wait 5 minutes and they know that that's their onset, I would feel comfortable agreeing with that. And then duration, as you can see, does not last very long, which is great if they're having a side effect. It's not going to be a long-standing issue, but unfortunate if they're having to redose every couple hours and also expensive. So not the best formulation for symptoms that are persisting throughout the day and night, but definitely something we will rely on for as needed or PRN types of care. And that differs compared to swallowed. So swallowed, we are now involving the GI system. We're relying on the intestines to properly and passively absorb these lipids. And that also requires the use of bile salts. So there's a time differential here. There's a lag in onset. And that could vary anywhere between 1 to 3 hours. Every now and then I'll meet someone that says it takes 30 minutes to kick in. I think that's great. That's just like what ibuprofen or acetaminophen would take. So you have that like reasonable expectation. But then every now and then it takes 5 hours and then you forget you take it. So it kind of sneaks up on you. So a lot more difficult to predict the onset with swallowed formulations, even though they're easier to take. There's no required device counseling to take a pill. It's a lot easier and simpler for patients. But again, as we're involving the liver, the hepatic system through the portal vein, we're also encouraging enterohepatic recycling, and that's what leads to these variables in duration. A swallowed form can last anywhere from 4 to 24 hours. I will always recommend new to therapy patients will start just once a day, preferably in the evening if it's THC, and see how they feel the next morning. They could still have persisting effects from the previous dose, and it very well could last 24 hours. So there's no target dose when it comes to cannabis. It's not like I absolutely need you on 10 milligrams to treat your night terrors because that's what the clinical trial said. It's more so of how do you feel, and subjectively, are your symptoms controlled and you're not having impairment, we can continue. Last but not least, because the liver is involved as well, we're going to have more drug interactions, and I will discuss these a little bit more detail later on in the presentation. So kind of in the middle is our oromucosal. So this is going to be under the tongue, in the cheek, on the gum line. And I kind of see this as that in between. It's not as fast as inhalation, but it doesn't have as great of a lag as we would see with enteral or swallowed forms. But we are still going to be swallowing it. So we do see that extended duration. And my only counseling with this is a lot of these forms, besides the buccal tablets, will require some form of manual dexterity. So having to manipulate a syringe and see the graduations, depressing the actuator on a spray. Not everyone has the strength to do so. So not a formulation for everyone, but it wouldn't be cannabis if not every formulation had its pros and cons. So this is something I will draw for patients that are new to cannabis, new to medical cannabis. And it's just an estimate because patient expectations are very important here. If they take a pill and think it'll start working as quickly as their hydrocodone, that might be an issue because they might redose and then have that over medication happening. So again, inhalation, fastest onset, highest Cmax, and shortest duration compared to swallowed with that variable lag time for the onset, and then again, that variable duration, but typically has more of a plateau type effect. So these next formulations I consider to be more local. Based on the studies that are available, we don't really see systemic toxicity, which is one way of determining if we're having good bioavailability. So we don't really see the systemic toxicity with suppositories or topicals. So for suppositories specifically, when you look at all the rectal suppositories, they all use this prodrug, THC hemisuccinate. So it's a proester. It's specifically designed to overcome the poor bioavailability of THC, especially through rectal routes. So I don't think we can compare apples to apples when you see these studies on suppositories using this hemisuccinate prodrug to the suppositories that are just pure THC. So we will assume there's a reduced bioavailability for those forms. So just because of that, I just assume these will be local effects. For rectal, that could be for like ulcerative colitis. For vaginal, I'll commonly recommend this for menstrual pain, endometriosis. I'm starting to also recommend it for transgender male to female conversion because the dilation process can be very painful. So if we can provide local anesthetic type relief without the undue impairment of THC in the brain, that would help patients be more compliant with their dilation. And then last but not least is topicals. I would never recommend a topical as a mainstay treatment. I think of it as more of an adjunct or a complementary type medicine, especially like I think of patients with fibromyalgia. They have widespread pain and analgesia and sensitivity, nerve pain, anxiety. They have all these different symptoms throughout their body. I can't reasonably expect them to douse their whole body in a salve. That's neither realistic nor cost effective. So I see these as more of add-on if they have specific areas that, they have an area of spasms that they want to target directly. I'm a big believer in the visualization when it comes to the endocannabinoid system. It's, the mind over matter. It's where your energy goes. So I think there is a valuable component to, touching the area that is tender or sore, for example, Same thing with inhalation. If you can visualize the vapor going to that specific area of your body, that can also provide relief. And placebo is my favorite drug. So no side effects there. So moving on to side effects, adverse drug reactions, we're going to start with disease state precautions. So in summary, I do not recommend starting THC in any patient with unstable cardiac or psychiatric or any condition of the brain, really. I would never go more than a balanced product in patient that had some psychiatric condition, whether it was a stable diagnosis of bipolar. Same thing with respiratory. I wouldn't recommend any inhalation route. Usually those are temporary. There are some studies that show that THC has a bronchodilatory effect. But again, I'm not going to recommend that when we have an infection on board. It would defeat the purpose. And here's my drug interaction slide for you. The next one is prettier, I promise. So what I like to highlight here are, well, anything you smoke is going to induce CYP1A2. That doesn't matter if it's a joint or a forest fire. It's going to have the same impact on the body, on the liver. And then with THC and CBD, they are both substrates and inhibitors of CYP3A4, which is the most common pathway, so nothing really surprising there. One thing I like to note is THC is metabolized into its active metabolite, 11-hydroxy-THC, presumably via 2C9. And CBD is a 2C9, is a very potent 2C9 inhibitor. So the thought is that perhaps CBD helps cushion THC side effects of anxiety and tachycardia and really that psychotoxicity that can accompany THC because of its reduced conversion into its stronger and more active metabolite. So I think they've tried to prove this, but it's difficult to prove. It might be more so during the receptor interaction, just the way that CBD binds to the receptor and modulates THC's binding. That could also affect the cushion, but that's a theory we have. We're working through it. This one I will not go into detail, I promise. I just thought while I'm here, I may as well stop. You can stop and take a look. So there's a lot of interactions with CBD and THC. CBD has very poor bioavailability. I think that's actually a saving grace when it comes to the sheer amount of inhibition it can produce on CYP enzymes. So I think about how CBD is readily available in gas stations and grocery stores, and patients are picking it up and not even realizing it could be interacting with their other medications. And so the fact that it probably has a 10 to 20% bioavailability is probably helpful in those cases to reduce the chance of drug interactions. And not every side effect is a bad thing. So there are some side effects or unintended effects that are good things. They could be goals of therapy. I think of patients with neurological disorders that are accompanied with drooling, like ALS. The dry mouth could help reduce that drooling, that oral irritation, and make it a little bit easier to eat, perhaps. Sleepiness, most common side effect reported with THC, obviously would use it at nighttime for insomnia. And then euphoria, it's always listed as a negative side effect, but in patients that are utilizing palliative or hospice types care, that would be the goal of therapy. Again, and we don't want it to the point where it's uncomfortable. That would be dysphoria. But finding that there are differences in each person and each body, every body metabolizes these cannabinoids differently. So we have to be very cautious and judicious with our dosing. Here is a list of the most common cannabinoid-specific adverse reactions, and it's important to differentiate if an adverse reaction is cannabinoid or formulation specific, because that will help determine our adjustment. So I kind of went through most of these: dry eyes, dry mouth, self-limiting, or stay hydrated. Not much we can do from a pharmacological standpoint, besides, eye drops and drinking enough water. But when it comes to THC side effects, it's much easier to prevent than to treat. So that's where we incorporate the start low. For a cannabis naive patient, that would be somewhere like 2.5 milligrams of THC. We would go slow. So again, there's no rush. I think the challenge is a lot of these patients have tried every other pharmaceutical and they're willing to try something that's still federally Schedule 1, still federally illegal. And I think there's a a stigma still associated with it. But I don't like to use the word desperate. But a lot of these patients, they can be desperate for relief and they think more is better. And it's our job in the dispensaries to educate and say no. More is just more likelihood of side effects. And sometimes just that adverse reaction, if you have a side effect, you may be discouraged from trying it again and experiencing that, especially if it was really bad or traumatic. They're not life-threatening, but these can be life-altering side effects if you do have that dysphoria or that paranoia or panic type effect. And then the stay low piece, that's just alluding to like we don't have a target range for dosing. By doing that, by increasing doses unnecessarily, we're just increasing the chance of tolerance, which will increase our ultimate doses and also increase cost. So like to avoid that if we can. With both THC and CBD, they both have the potential for biphasic and paradoxical reactions. So biphasic means different effects at different doses. At low doses, THC is anxiolytic, it is antiemetic, and quite the opposite at high doses, it can be anxiogenic and it can be emetic. So it can increase anxiety and increase nausea. So less is more when it comes to THC. And the paradoxical reactions, you can't always predict it. I have noticed that for some of the pediatric patient populations I'd see, CBD would be more hyperactive, whereas in adults, they would have more of a somnolent effect with CBD, but it depends, right? That's kind of the whole reason it's not FDA approved because it's so variable. It's so experimental. We can't predict the effects, and there is that very serious experimentation component to this. So last adverse reaction is related to formulation-specific side effects. So for some of these, we can provide device counseling, like for inhalation, if there any throat or lung irritation or cough. We got to revisit the technique that we're using. The challenge is they can't take a puff in the dispensary, so to kind of play make-believe. But it's a device, it's an inhaler just like anything else. There's a technique to it. And if it's not comfortable, the patients aren't going to want to use it. And then with swallowed, I like the mnemonic, meals then medicine. If there's something in your gut, and this kind of goes for any medicine, any drug, if there's something in your gut, you're less likely to feel that GI upset, that abdominal cramping. Technically, meals and medicine can also help with the THC specific side effect of increasing appetite if we're not looking to increase appetite. So if we're well fed, in a well-fed state, our body will not be starved of calories and seek junk food, aka the munchies. So there's ways to help mitigate those side effects in patient populations where we don't want to see it, like diabetic neuropathy. And then the last thing I'll mention for oral mucosal is have to review the concentrations. I've seen products 5 milligrams per milliliter all the way up to 50 milligrams per milliliter. And a lot of those bottles are very confusing because it has the total number of cannabinoids in the product, and it then says the serving size and how many servings. And it's like all of a sudden you get into this complicated math that patients don't have to usually do, and they just kind of ignore it. And then now we're, chugging this highly lipophilic molecule that's usually in an oil-based substrate. And all that liquid, all that oil is just causing gastric distress. So making sure that we're mindful of how much oil they're taking in as well and how much we can reasonably leave under the tongue. It's another consideration when it comes to oral mucosal. All right, a last section here. So we have the sweet spot. So this is the embodiment, another figure I'll draw for patients, but this is the embodiment of start low and go slow. I would rather start someone and have no effect. So at the bottom of this figure, because we can always take more. If we start and have a side effect, they're going to be less likely to want to try it again. So if we start slowly, increase comfortably, for me, that is THC every 3 to 5 days, depending on the patient. If they are using CBD, I would typically go 1 to 2 weeks. Just remembering CBD has a longer half-life. The drug takes longer to kind of kick into effect. And also the patients that are typically using CBD are just vulnerable patients in general. They're pediatric, they're elderly, they have epilepsy or something. These types of conditions, they're just more likely to have side effects. So we'd rather let the body guide us and titrate a little bit slower. And then we see above the sweet spot, that's where we have side effects. So that's the dose is too high, we have to back down. And so I've developed the cannabinoid experience rating scale. I affectionately call this CBERS. And this just helps clinicians identify which component of the regimen might need to be adjusted. Because if the patient is doing well, there's no bothersome symptoms, no bothersome adverse reactions, that's a CBERS of 0, no dose adjustment needed, continue therapy. But on the left-hand side, on the negative side of the number scale, that's where we're continuing to have symptoms. Is it because the dose is too low? Is it because we are timing this twice a day and there's breakthrough symptoms and it should be 3 times a day? Or is the formulation ineffective? Does the patient just not want to use the pills, or can their body not absorb the highly lipophilic molecules? So left side is symptoms are persisting, and that's a negative. And then on the positive side of the number line, we have side effects. So again, is it dose related or ratio related? Could this be the timing or just the formulation specific side effects that we just went through? So I do have a couple patient cases just to kind of help see this live. So our first one is Sally, 54-year-old female with diabetic neuropathy and insomnia. Current medications of relevance, I included gabapentin 3 times a day and amitriptyline 25 at bedtime. And her goal of therapy is to help with her nerve pain and sleep. So we start her on 2.5 milligrams of THC. We start once a day. We slowly rev it up to 3 times a day over the course of a week. And there's just no perceived effect. CBERS -1. So logically, we double the dose. She already has it at home. So we take 2 pills. And now we're having uncomfortable side effects. We're having dry mouth, dizziness, and this is all happening relatively soon, relatively after administration. So it's clearly a cannabinoid related adverse reaction and not timing related. So this is a CBERS of +1. We have to change the dose. So we can add CBD. This will be the easiest recommendation because, oh, I guess not the easiest. Easiest would be if she already has some at home. She'll probably have to come back into the dispenser to buy a new product. But this would be our recommendation because we know that the 2.5 milligram THC is ineffective on its own. The thought is that we can add CBD. Perhaps the CBD would help with her nerve pain or sleep. And that is when I would recommend going back to that 2.5 milligram dosing range, starting there, and then potentially, if she felt up for it, we could start at 5 milligrams because we know that the 2.5 was ineffective. And we hope that the 5 milligram of CBD would help offset some of that toxicity with the 5 milligrams of THC. So again, there's 100 million possible recommendations we could do. But for this example, I just wanted to show how we can adjust the ratio to help with the THC specific side effects. And in our last patient case, we have Marvin, a 35-year-old male with PTSD, OCD, and insomnia. Current medications include escitalopram and buspirone. And his goals of therapy are night terrors and insomnia. And he's currently using cannabis. So he's using it already, but it's not working well for him because he's having to wake up in the middle of the night. So in that case, you could argue it's timing. But no matter what you do, no matter what we change, I can't make that vaporizer or that inhalation last longer. It's going to get out of the body as quick as it will. So we have to change the formulation. So this would mean switching to a longer acting formulation. And I'll just kind of hypothetically go down this a little further. So let's say we put him on 5 milligrams before bed and we tell him to monitor. So you always have to continuously reassess and make sure, first and foremost, no new side effects are presenting. So we check in with Marvin and we say, how are you feeling the next morning? And if he says something like, oh, I'm waking up with like a hangover effect, I feel groggy, dizzy, I still feel sleepy, I can't, turn off my alarm. That would indicate to me a timing issue because the effects are persisting longer than we'd like them to. So in this hypothetical example, I would tell Marvin, take your THC after dinner. So give it some time earlier in the day. Hopefully that's enough to help it wear off. Whether this, let's say, was a capsule, maybe if that still wasn't working, I could try a liquid, so something that would work hopefully a little bit shorter, but again, not as short as the inhalation route, which we already found to be ineffective. So I threw a lot at you. I do have time for questions. I didn't see any in the chat, but I don't know how you guys are doing Q&A. So I will leave it up to the moderator. Thank you.
Thank you. We have a couple minutes if anybody has any questions for any of the speakers. He'll bring you the mic.
Dr. Kane, thank you so much for your excellent presentation. I just had a couple of comments that had to do with the dosing of THC and CBD. I have found, kind of on the converse side, that I have used CBG. I call it my reversal agent. I use it a lot with orals or people that maybe go a little bit too far with their dosing of the gummies, and then the next morning they're finding that they have to drive, they're feeling a bit wonky. So I go ahead and recommend probably a 60 milligram dose of CBG. So if you could comment on that. And then the second one is, if you could comment briefly upon maybe some of the smoking formulations of the THC CBD, such as Harlequin strain.
I'll start with your first question. My baby is sick, so I'm not getting a lot of sleep. So I'm gonna have you repeat it in a sec. But um, the first point, so reversals. There's a lot of anecdotal stuff. Obviously, caffeine, tried and true, probably the most used drug in the world. There's also things like chewing black peppercorn because of the beta caryophyllene, lemon for the limonene portion, or something with like pining, so the pine to help kind of wake you up. I have not seen anything about using CBG. I'm trying to remember its interactions at the receptor. I don't think it interacts the same way that CBD does. I'll give you a story. I did have a patient that was very well controlled on 20 milligrams of THC 3 times a day. She had like I think it's pronounced Duchesne's disease. I don't know how to pronounce it. I swear I can pronounce the drugs. But it was like a muscular dystrophy type of thing. So she was like doing very well. And she went to like a cannabis expo and they had like free sample stuff, and she tried CBD, and she told me that as soon as she took it, it was like she took Narcan. That's how she described it. She said she took it and it was like immediately her paralysis came back, her cramping came back. And I mean, I told her, I was like, well, clearly that's not your molecule of relief. But just as an example, these cannabinoids interact with each other, ideally in a way that helps, sustain therapeutic and symptom relief, and not in a way that, causes side effects or something like that. But definitely, if it works, I'm all for it. I have no idea about CBG. I don't know how expensive it is and what that 60 milligram dose looks like. So good on you for finding that. Publish it. I'll read it.
It's Duchenne's dystrophy.
Shane's. It's like you see it and you never pronounce it, and you're like, yeah.
Just think
Sorry.
Duchenne. The
What
second
was your
question
second
was,
question?
I don't know if you recommend flower too much, but I just wanted a brief comment on various strains that are high CBD, and then I use the strain of Harlequin.
Yeah, so I don't use flour too much, just because I give the example of, if you're holding an orange, can you tell me how many milligrams of vitamin C are in there? So unless you're doing the proper analysis, you have no idea what's in there. And as a pharmacist, my goal is always to have consistent and reproducible effect. So if I want to keep the supply chain going, I need to make sure that those products are available and consistent. That's why we do lab tests. So if the flower that someone is personally growing can be tested, great. It's just there's so many variables: the light, the soil conditions, the nutrients that are being provided, just the genetics in general. So there's so many different factors that can affect the dry flower itself. So I do find it more difficult to have a predictable response to, but I'm all about safe extractions. I think rosin is gaining a lot of popularity for good reason. And I am very familiar with Harlequin in terms of the strain. I just believe, and this might be me being in the industry for some years, every single state calls it something different. Everyone has their own proprietary strain names and genetics and this and that. And if you look up some studies from Anna Schwabe, I did not reference her in the study, but she does a lot of genetic testing, and indica sativa is basically a moot point. And the strain names that we use, they just describe the genealogy. Who are the parents? Where did they come from in terms of strains? But they don't really give us ideas of the chemical or the chemical effect. So I always prefer, especially when I do continuing education, I always prefer just keeping the chemovars consistent, THC dominant, balanced, and CBD dominant. That way, healthcare professionals can all be on the same page and patients as well. So unfortunately, all these additional cannabinoids, we're adding drugs to the ratio, adding numbers, and you never know which number's first. In my state, it is mandated that THC comes before CBD in the ratio. In Colorado and Israel, you have CBD first because it's more niche. So I think that is just increasing the risk of medication errors because we're not all speaking the same language. That was a little bit of a rant. I'm sorry.
Pharmacist and, about consistency, but the interesting point that you underscore is the difference between cannabis medicine and conventional pharmacology and pharmaceuticals, as was mentioned in a previous talk earlier today. Patients, we expect to do more self-titration, and I think just like in the world or even medications such as over-the-counter things, the absorption and the onset and duration are going to be affected by the state of the patient's hormonal state, the patient's homeostasis, whether the patient's eaten or not eaten, and how recently their hydration, et cetera. So again, I think the message that we should be giving to our patients is we have to give them some control. We're making recommendations and they need to self-titrate to the effect that they need rather than a consistent specific milligram dose. So while I respect consistency in dosing, especially with studying Dr. Kane, I would argue that for many of our patients in a clinical setting, it really is, 10 milligrams might be too much today and not nearly enough tomorrow in the middle of something else going on. So adjusting individually, starting low, going slow, and adjusting to clinical effect, I think is really an important mantra. And with that, is there any other burning question before we close? I think one last question, sir.
For Dr. Wilson King, did I get the name right?
Yes, Dr. Wilson
Yeah.
King.
So I'm sorry. So we were talking about for the PMS and PMDD, you were saying the CBD at 10 milligrams worked better than 30. So 10 milligrams, is that a daily dose or broken up to several times a day, or?
Okay. So, right. So that's why it's like that. And I don't really have those specifics from the study.
Any empirical evidence you'd suggest?
Well, cannabis is always less is more, as far as I'm concerned. The seem to work a lot better than the higher doses. There's the curve, the bell curve, and then you have, so I would teach the patient how to assess when they get to where things work. So I like the idea of what was said about patients to have control and whatnot, but we do need to educate them and inform them prior to that. So that's why I say less is more. And
Okay. Thank you very much. Appreciate it.
Thank you. Thank you to we have one more quick announcement.
Sorry. So in the exhibit hall next door, as you walk in on the right, there is a poster. You don't really even have to read the poster. I'm helping my own child do a study. It's for people who certify patients. You click on the QR. It talks about what we all know about testing for contamination in products. And it would really help us so that we could move this study forward, if you would do that. Thank you.
Thanks, Dr. Kane, for being here remotely, and 20-minute refreshment break and reconvening here sharply at